enjoyed your lunch, and this is going to be the last two sessions for today, and I hope you will enjoy it and find it interesting. It's my pleasure to present the chairperson of this session, Professor Charlotte Kamel, who is a professor and consultant of psychiatry. She has a very rich bio. I just picked a couple of things. That she is fellow of the Royal College of Psychiatrists. She moved to the Kingdom of Bahrain since 1988, and she participated actively with her colleagues in developing the mental health services in Bahrain, tailored to the British system. She joined the Royal College of Surgeons of Ireland, Medical University of Bahrain from 2008 as an associate professor and head of Department of Psychiatry till date. Bottom line, she's an honorary member of British Medical Association, American Psychiatric Association, Bahrain Medical Society, and she's vice president of the Arab Gulf Psychiatric Association. Please welcome Dr. Charlotte.
Thank you very much for inviting me to this great conference, the WPA Thematic Conference of Psychiatry, which is usually a very successful occasion. It's my honor to join it, and it's my honor to share this session. For the sake of time, I will start straight away by presenting the first presenter, Ms. Fadwa Al-Muqaddam, a PhD student, Dr. Fadwa Al-Muqaddam, a student in public health and a medical research specialist in the Psychiatry and Behavioral Science Department at the College of Medicine and Health Sciences at United Arab Emirates University. She has the experience of working in mental health clinical research since April 2010. Previously, she worked as a researcher in medical sciences, laboratories, and departments at CMHS. She is a good team player, enthusiastic about clinical research field with many interpersonal skills. She also has an interest in mental health and public health research in UAE, specifically cognition and memory problems among UAE population. It's something that we need to develop it, and we will be very happy. I invite the audience to listen actively and participate with questions. Please.
Good afternoon, everyone. It's my pleasure to be today with you and to share with you part of my PhD project, which is entitled of First Step for the Cross-Validation of the Arabic Emirati version of the Subjective Scale to Investigate Cognition in Emirates, the STICKY tool. So the first slide is showing the outline of today's presentation. I will share with you a brief introduction about some epidemiological data on cognition declines, and I will discuss with you the importance of the cross-cultural validation studies. Then I will share with you the aim of the study, the methodology, some of the preliminary results, and finally I will conclude with a small summary and acknowledgement. In 2012, US conducted a study about the prevalence of mild cognitive impairments, and their result concluded that among adults aged 65 and over, the mild cognitive impairments estimated to be 22%. And their data were collected from health and retirement survey data, In 2019, another study conducted in Saudi Arabia from community-based study in Riyadh, and they found that the cognitive impairment was 45% among 60 and above adult. And based on records generated from the WHO in 2021, the estimated global prevalence of mild cognitive impairment among adults aged 60 and over was estimated to be 22%. So why we are here today and why I'm discussing with you cross-cultural validation study? For any novel psychometric instrument to be applied in a different culture, it needs to be appropriately translated and validated, as self-reporting scales are susceptible to significant alterations resulting from social attractiveness, suppression, and response style. Of course, using standardized and validated research instruments to measure responses is essential, as well as cultural adjustment of any instrument, reduced cost and time spent rather than forming new scale. So the process of cross-cultural validation allows the translation of a clinical instrument into different language. It is considered as a complex process when translating languages because of the possible interference of cross-cultural and ethnic factors. A large commitment of time and money is needed to complete the challenging process of cross-cultural validation of any evaluating tool. This function contributes to identifying any possible variance in the phenomena studied among the selected population. To create a translated instrument that is culturally equivalent, the technique of equivalence considers something very important. The technical equivalence should be directly related to the assessment method and not interfere with the result obtained from one culture to another culture. The objective of an adaptation is to obtain a tool that is both valid in this context and of the sufficient cultural universality for its use in other populations to require little or no adaptation. Cross-cultural validation generally carried out cannot produce a more valid version than the original version. So what was the rationale behind conducting such project in the UAE? We found that there is a huge need for a culturally adapted tool that can be easy used and practically reused and self-assessed or self-administered tool to be provided for the UAE population, as well as cognitive complaints and lack of cognitive insights in population at risk of cognitive decline is an important problem that needs to be emphasized and addressed. Also, investigating and collecting data on population at risk can help to prevent reaching critical stages of all of the illness. So the aim of the study was to develop and validate the subjective scale to investigate cognition in Emirates, adopted from the subjective scale to investigate cognition in schizophrenia, the STIX instrument. Our study included two objectives. The main objective, which is the core of my presentation for today, is to translate, adapt, and validate the subjective scale to investigate cognition in Emirates, the STICKY tool. The second objective was to study the relation with an objective measure of cognitive difficulties using Montreal Cognitive Assessment Test. Our research methodology followed observational cross-sectional validation study design. Our selecting technique was snowballing sampling techniques, and the eligibility criteria that we agreed upon was all adult male, females aged 18 and above speak Arabic and consent to participate in the study. For the clinical subjects, the participants need to be diagnosed with mental health disease based on ICD-10 and DSM-5. The exclusion criteria will be any participant less than 18 years old, do not speak Arabic or refuse to participate. And for the clinical subjects, those who have any mental retardation, substance abuse, or intellectual disabilities have been excluded from the study. So the main protocol of the study followed 4 main phases. The first phase was the translation and back translation of the original scale to generate the Arabic version. The second phase was pilot testing the Arabic translated version and tried on 13 subjects. That's followed by the third phase, which is obtaining all the ethical approvals that will allow us to conduct and apply this tool among clinical subjects or healthy subjects from the community. And the fourth phase from this protocol was the subject enrollments based on the eligibility criteria. So let's introduce the scale for you. What is the subjective scale to investigate cognition in schizophrenia? The STIX. The subjective scale to investigate cognition in schizophrenia is a scale that created and validated by Professor Emmanuel Steb and his colleagues in Montreal, Canada. This scale was initially validated by 2 official Canadian languages, the French and the English. It is a form of Likert-type self-assessment questionnaire that consists of 21 questions. Each respondent have been asked to choose 1 from 5 options, starting from 0, which is never, reaching to 4, which is very often they have this challenge or they have this problem with cognition. The scale consists of 5 main domains to assess the subjective complaints. The domains are memory, attention, executive function, languages, and praxia. As we can see in this slide, this is a brief description for the scale domains. Each domain will be assessed by particular questions that the respondent need to give an answer for that. As we can see, memory will be assessed by working memory, explicit long-term memory, from question 1 to 11. And the whole domain, the main domain, which is the memory, all the questions from 1 to 11 will evaluate the memory domain. For the attention, the questions from 12 to 16 evaluate the subdomains item like distractibility, alertness, selective attention, divided attention, sustained attention. And for the executive function domains, questions 17, 18, and 19, they are measuring or assessing the planning, organization, and flexibility skills. Language is assessed by question 20, praxia assessed by question 21. How we conducted the process of translation and back translation for the scale. The first stage, we had to test the 2 original versions of the scale, the French and the English version. In the second stage, 1 single researcher who's blinded to the Arabic Tunisian translated version of the scale, the SACS version, which is self-assessment scale to cognitive complaint in schizophrenia, have been assigned to do the Arabic translation, the Arabic Emirati translation for the scale. The third stage, the comparing between the 2 translating Arabic conducted, and the 2 Arabic scales have been translated back into English. In the fourth stage, 1 reviewer compared the 4 English versions and choose the most close one to the original scale. The final stage was the harmonization stage, where meeting held between the different people involved in the translation to examine the divergent items and concepts to ensure intra-translation validity. In the screen, we can see the English scale, which containing the 21 items or questions. And in the other side of the screen, we can see the Arabic translation version. Here I can share with you some of the preliminary results from our sample population. Our sample population included 210 subjects. Among those, 126 were patients and 84 were control. The majority of them were women in both groups, and the mean age was higher among the patients group than the control group. It was 40.4. The national were more in the whole sample, but there were more in the patients group as well. The STIC average score was higher in the patients group than the control group. It was 44.1. And the Montreal Cognitive Assessment average score was lower in the patients group, which is expected, than the control group. It's 22.7. In summary, our study aimed to validate a self-administered screening tool called the Subjective Scale to investigate cognition in Emirates that assess subjective cognitive complaints among UAE population. Cultural and language factors should be considered when developing a tool to assess cognitive abilities. Sticky is a practical and useful tool that can be used by individuals in the UAE to assess their cognitive abilities. I would like to acknowledge College of Graduate Studies for funding this PhD project in the UAE University. Special thanks and acknowledgement for Psychiatry and Behavioral Science Department members, Public Health Institute members, and all the participants and their families from the community for sharing their responses with us in this study. Special acknowledgement and thanks goes for Behavioral Science Institute in Al Ain Hospital team and Tawam Hospital Psychiatry Clinics. Special thanks for Dr. Moses Busia and her teams, all the psychiatrists, psychologists, residents, nursing team. Special thanks for patients and their families for trusting the research process in the UAE and giving us the opportunity to participate in this project. And of course, the main thanks and efforts will be going to the Prof. Emmanuel Stepp. He's not with us here today. He's my direct supervisor and direct manager. I would like to thank all the support and encouragement that he gave me all this time in this project. This is the references. Thank you very much for your attention and your time.
And this important topic, which is, mentioned in any conferences and international conference we go to. Our second speaker is Dr. Afaf Ibrahim Shehi. Is she available, Dr. Afaf? Okay, Dr. Afaf is a consultant liaison psychiatrist at Royal Hospital, Ministry of Health in Oman. She has had 12 years experience of psychiatry field, including clinical work, research activities, training junior doctors who are specializing in psychiatry. She completed 2-year clinical fellowship program in the subspecialty of consultation liaison psychiatry at King's College London in 2018. Since that time, she has been working on setting up the consultation liaison psychiatry service in Ministry of Health hospitals and creating clinical guidelines. Since it's relatively a new service in Oman, as most of our countries in the area. She also had a special interest in old age psychiatry, and she is the chairperson of Scientific Committee of Oman Alzheimer's Society. So please start, Doctora. Welcome.
Good afternoon, everyone. Thank you, Prof. Kamel, for introducing me. First of all, I would like to thank the organizers of this Congress for giving me this opportunity to be one of the speakers today. I'm going to talk about one of our recent studies we have completed lately. It is about national psychotropic prescribing patterns in older adults in Oman. So I'm going to talk about, first of all, background information, literature review, and situation of Oman, and then I would describe details of our research project, and then we'll talk about future recommendations. There is no conflict of interest to declare, and no fund was required for this project, and ethical approval was obtained from Ministry of Health Research Committee. So I was honored to work with a great team, consists of 12 consultants and psychiatrists and specialist psychiatrists in all regions of Oman, and also the special thanks to Dr. Hamid Al-Sinawi, who's senior consultant old age psychiatrist in Oman, who provided expert guidance and intellectual feedback on the progress of the research. A bit of background information. Literature found that there was a high rate of psychotropic medications used in elderly people worldwide, and psychotropic consumption is mostly oriented at symptoms or syndromes, which explains why benzodiazepines are still the most commonly prescribed psychotropic agents. I think it's not organized well. The term potentially inappropriate prescriptions, PIPs, is well known in the literature. There are two explicit criteria are commonly used worldwide, the Beers list and STOP criteria to test for these inappropriate prescriptions. The STOP criteria has been endorsed as a best practice by some organizations, and the STOP criteria appear to be more sensitive than the Beers criteria. There are several studies conducted regarding PIPs, and the prevalence were ranging from 62 to 73 in different countries, in different, across different times, like 2004, 2011, 2019. And benzodiazepines and the receptor agonist hypnotics were the most common PIPs and accounted for 15% of the total PIPs in a study conducted in China. There was also a series of 4 studies done in the US in the 90s, and they concluded that the PIPs of psychotropic drugs were very common for elderly patients in the outpatient setting, and the most common medications involved were amitriptyline and long-acting benzodiazepines. So let's talk about the situation in Oman. We have a large land. The country administratively is divided into 11 governorates. Each governorate is considered a health region. And the Ministry of Health is the main healthcare provider. Psychiatric clinics are distributed in secondary healthcare institutions in all the governorates, and they are run by mainly specialist psychiatrists. But at a couple of regions that are run by consultant psychiatrists. And they are considered as a local psychiatrist or community psychiatrist who see all patients attending either a walk-in or by appointment across all ages, children, young adults, and older adults. And there are no subspecialties in these regions outside Muscat, the capital. Oh, sorry, I'm going for it. Yeah, we have challenges. I think it's not only in Oman, maybe in a lot of Arab countries, that there Muscat is, you see, is like a small region but like dense in population, and the main challenge with us is centralization of care. So in the other regions outside Muscat, let's talk about Muscat. Muscat have tertiary hospitals, teaching hospitals with all subspecialties. While outside Muscat, we have only like general psychiatrists, and also there was lack of proper medications for elderly people. The newer medication, the costly medications, will be only are usually only available in the teaching hospitals, and only can be prescribed by consultants. While in the regions outside Muscat, these medications cannot be prescribed, like the newer medications, the aripiprazole, quetiapine, and from the antidepressants, the mirtazapine, sertraline, and also SNRIs. And also, of course, no old age subspecialty in outside Muscat, and admissions only, we have to refer to Muscat, the tertiary hospital, for admission. So how this idea came to me. Before I work in Royal Hospital in Muscat, I work in a regional hospital in a very small town, and I was struggling with finding an appropriate medication to prescribe for elderly people. It was difficult to refer them to Muscat because it's far away. So I thought maybe we need to address this problem formally and in a scientific way, and then present it to the Ministry of Health to find a solution. So the aim of this, the objectives of this study were to study the pattern of prescribing psychotropic medications for older adults in psychiatric clinics in Oman, screen for inappropriate prescribing practice, and discuss ways to minimize inappropriate prescribing practice and plan for future studies. So it was a retrospective study using the information in patient's medical record, and it is only a descriptive study. There was no complex statistical methods used, and the data collection was conducted manually by the psychiatrist, the research team, and it was conducted in 12 healthcare institutions, which equally represent all governorates of Oman. All patients who are aged 60 years or above who attended the psychiatric clinics in secondary healthcare institutions from January 2019 to December 2020, so 2 years, as a new case, and whom a medication was prescribed for them in that visit, were included. The following patients were excluded who were not prescribed medication in the first visit for whatever reason. Either they don't need medication, or they came for a report or anything else. Or patients who were prescribed medication in the first visit as a refill, but prescription was initiated by another hospital, like a tertiary hospital. And all psychotropic medications were evaluated, antidepressants, antipsychotics, mood stabilizers, dementia medications, and others. I used STOP criteria this is my measures. STOP criteria were applied to detect PIPs. I don't know how we can get the link. Yes. So can you scroll? This is the STOP criteria. There is a long list. It is not only for psychotropics and CNS. It is for cardiovascular, respiratory, and other system, all systems. So we'll focus on only CNS, like one example, prescribing tricyclics in dementia and cardiac diseases and glaucoma, and in BBH. Long-term prescribing of benzodiazepines more than 4 weeks, and also prescribing diazepam or any long-acting benzodiazepine. Can you please scroll? Yeah. Also using first-generation antihistamines. Okay, can you go back, please, to the... Okay, thank you. And the other measure is psychotropic polypharmacy in elderly people. Actually, there is no constant definition of what is psychotropic polypharmacy in elderly. Some studies say it is 2 or more. Other studies said more than 2. But I chose the more strict one because it is like a new presentation. So it's expected, we can justify why we need to prescribe another medication in the second or third visit if patient is not progressing well. But for first visit, we need to be more strict. Our results, there are a total of 1995 people attended the psychiatric clinics in this study period. But only 70% of them were prescribed. So our sample size is 1409. And gender distribution, female represent 59%, while male people represented 41%. Regarding antipsychotics, we found that risperidone was the most commonly prescribed among all other antipsychotics, followed by haloperidol and then olanzapine. Regarding the antidepressants, citalopram was, it was the most commonly medication used, followed by amitriptyline. Also, other medications were used, but the newer medications like mirtazapine and others, not the newer, the medication not available, they were prescribed from private pharmacy. And I forgot to mention that also private pharmacies are mainly, the medications are only available in Muscat, mainly available in Muscat. Regarding the sedatives and hypnotics, 18.5% of the patients were prescribed a benzodiazepine, and 35.6% were prescribed an antihistamine. And we found promethazine is the most commonly prescribed sedative medication, followed by clonazepam. We need to be more specific, and we assess the rate of medications prescription in specific categories of diagnosis. And dementia, risperidone, and promethazine were the most common medications. In anxiety and depression, citalopram and promethazine were the most commonly prescribed. In insomnia, where there was no diagnosis was made, promethazine, the antihistamines were the most common medications. For psychosis and delirium, the 3 medications, risperidone, promethazine, and haloperidol, are the most commonly used. When we assess the pattern of medications prescribed, when we compared people who are healthy with no medical comorbidities and with other people who have major medical morbidities, like the renal, the liver, metabolic syndrome, the cardiac, and cancer patients, there was no difference observed. Citalopram remained the most commonly prescribed among antidepressants, promethazine among sedatives, and risperidone among the antipsychotics. Rate of polypharmacy in our study is 38.9%, and rate of potentially inappropriate prescriptions is 6.9% based on STOP criteria, including use of long-acting benzodiazepine, which is diazepam, and 2.2% of the whole sample size. Prescription of anticholinergic like procyclidine in 3.4% of people, and use of tricyclic antidepressants in dementia, cardiac disease, BBH, and glaucoma represented 1.3%. Analyzing the results, our findings of high rate of psychotropic prescriptions in older adults is consistent with the previous international studies which reported that most visits to psychiatrists by elderly patients resulted in the prescribing of psychotropic drugs. Rate of the identified PIBs in our study is very low, it's 6.9, and I don't think this is the actual figure because we were unable to apply the whole, criteria because one of the criteria is how the length, the duration of prescribing antihistamines or benzodiazepines. So maybe the actual figure should be high. Two main issues have been identified from the current descriptive study: high prevalence or high percentage of psychotropic polypharmacy in the first visit, and high rate of prescribing sedative medications, benzodiazepines and antihistamines. And this warrants further investigation of these two issues in separate studies to identify risk factors. So future implications. Actually, we got these results several months ago, and then these implications I'm going to talk about, it was at the time future implications, but at time of now, it is, we have already worked on it. So further studies are required to address this issue, the two issues we found in our study. So we have already applied for ethical approval for the two studies for addressing psychotropic polypharmacy in the elderly population in Oman, rate and predictors, planning to find association between polypharmacy and demographic clinical factors using multivariate analysis, and also it will be on a national level. The other topic is benzodiazepines and antihistamine use among elderly people attending psychiatric clinic in Oman. It will be a descriptive study, and we will not do addition. We will use the same data we used for the original study, but we will collect slightly additional data, which has the duration of antihistamine and benzodiazepine use. Other actions are required to be implemented to minimize PIBs in elderly people, revising medications available in the Ministry of Health for this age group. And we already did this step and raised to the Ministry of Health, and I was actually part of the, we meet regularly with the head of mental health in the ministry, and we discuss already the need for certain medications. And already certain medications have been approved to be available in the regions outside Muscat for young adults. But there are certain medications still waiting for approval for elderly people. And also, I'm planning to, me and the research team are planning to initiate a continuous medical education to the psychiatrists in the regions outside Muscat and for the physicians in the primary health care regarding this aspect, the safety and the inappropriate prescriptions. And then this is my aim on the long term to get the experts in the old age field and set up, create a national guideline for prescribing psychotropic medications in older adults. Despite the strength of our study was like it is at a national level, it is at the base for future studies. It is like a quality improvement project on a national level, but still it has limitations. Like it is a cross-sectional study, retrospective study, where there are missing parameters. We are only able to find the data available in the system. We cannot create, other variables. So to conclude, the patterns of psychotropic prescribing for older adults in the outpatient setting in Oman raise concerns about two main issues: psychotropic polypharmacy and high rate of benzodiazepines and antihistamine use. Further studies are required to address these issues, and actions are required to be implemented to minimize inappropriate prescriptions in elderly people. And these are my references. And thank you very much for your attention. I'm happy to answer any question you have.
Thank you very much for two excellent doctors and two very interesting presentations tackling very important topics. The first one about the mild cognitive impairment assessment, which is
The subjective scale to investigate
yeah,
cognition.
and it is a point of great importance now, not only for elderly or special categories of patients, but it's it has to be tackled. And Dr. Afaf for the prescription guidelines. Okay. Please, the audience, yes.
Yeah, thank you for both presenters. I would like to ask Dr. Afaf about your question. Why still in Oman they are still using citalopram instead of new version of citalopram? And now we are in the process of forshoxetine. This is the one. Another, did you have in Oman system of controlling psychotropic medication, so it will be very easy to control the prescription either by psychiatrist in primary health care or even by primary health care provider in non-psychiatric setting? Thank you.
Sorry, doctor, the first question is why we use citalopram instead of escitalopram?
You use some of the psychotropics, which in antidepressant tricyclic plus citalopram,
Yes.
not escitalopram,
This
which
is
is Cipralex,
Yeah, the issue
which
of-
is a newer agent than citalopram. And we know that there is another generation like forshoxetine, and I am sure it is not available there, maybe. And if there is any registration for psychotropic prescription by the doctors. In UAE, there is all psychotropics is controlled.
Okay.
And mostly psychiatrist is writing this prescription. Non-psychiatrist is not eligible to write.
Okay. For the first question, as I mentioned, the main issue in Oman is unavailability of these medications. So the psychiatrist, only the available medications are citalopram. Citalopram is not available. That is why it is.
But according to my knowledge, it is a very old antidepressant compared to newer ones. And why it is not available? This is a question.
Well, doctor, I cannot. It's not clear. I mean, the voice.
I'm telling, this is one of the older medication. And why it is not available? My main question, why it is not available new medication?
Well, may I
Why the
intervene?
medicine is not available? Why it's not available?
May I intervene just to help Dr. Badr? Thank you for the question, but I don't think Dr. Afaf, she can answer. She is not in the position to tell why this medicine is available, why.
This is.
Sorry, Dr. Mufid, she presented topics related to available psychotropics in Oman.
Yeah.
And my concern, this is very few number of psychotropics which is
Yeah.
presented. And
Doctor,
to make things, to make service better, to control this polypharmacy in older age group, you have to find another agent which is safer, not like benzodiazepine with long time.
I totally agree with you, doctor.
Thank you.
Yeah,
I mean,
this
the
is
tertiary hospitals in the capital city, all medications are available. This is the issue, the centralization of care. I mean, that's why I came with this idea to raise it to the Ministry of Health to realize this problem and start working on it. So my aim is to, yes, this is what we say, we need to make these medications available, teach others how to use it and how to avoid other unsafe medications.
Yeah.
Thank you.
Thank you. Any other questions? Comments?
Other questions? Okay, I will ask you about my cognitive impairment.
Yes, it's okay. Just make it
Can
closer.
you hear me?
Yes.
Yeah. About the mild cognitive impairment. Are you planning to follow up this study? Because it is well known that if you find patients with mild cognitive impairment, always above 55, some of them can develop Alzheimer's disease later on. Are you planning to follow up have a follow-up of this study?
This is the first stage of this study.
Yeah.
We just want to validate the scale in Arabic, and definitely it can be used in several aspects in clinical settings,
Yeah.
even in the community. It can be very useful for decision makers or healthcare provider for choosing the best intervention for sake of the patients to improve their quality of life in the future, specifically before the progression of dementia, Alzheimer, other disease, schizophrenia. It is not only limited to schizophrenia, this scale. It can be used for any or many mental health condition or disease, general disease.
Yeah, of course. Even,
Yeah.
normal aging have some, they could have some mild cognitive impairment, but they judge it by the importance of effect on functioning.
Exactly.
If they are functioning, is okay. But if the functioning is disturbed, then it's a problem and it has.
I think it's important for each one of us to have the right insights about their illness,
Yeah.
to reflect if you have problem or not.
Yeah.
All of us here, we are control healthy. Some of us may or may not, in the future, I hope not, have any kind of problem.
Yeah.
We tend to forget, we tend to mix things, so many other skills, either by the limited time or by stress or overload, but when or how we can find or trigger ourselves, monitor ourselves if we need intervention from doctors, like clinical help.
Exactly. And why did they develop that? Why there was an upsurge of importance of talking about mild cognitive impairment in the last few years?
For the scale, you mean specifically?
Not only the scale, that concept, mild cognitive
Because
impairment.
the percentage of people worldwide, globally, the dementia and Alzheimer increase.
Yeah.
They are the 7 leading death cause,
Yeah.
both of them.
But not all of them develop Alzheimer's.
Yes.
If some of them have the mild cognitive impairment, but it doesn't affect the functioning. I read a review article. It's about many countries of the world now are extending the age of retirement. And people, they find that people, at the age of 60, some people are very functional, they are active, they can play a big role in the society still. So this is why, they started thinking. I mean, many people are active till 80. I remember the psychologist, Carl Rogers, who used to conduct marital therapy up till the age of 90 years old. And we have a photo for him, cutting the roses in his garden while doing marriage counseling to couples. So in extending the age of retirement, I mean, 60 is nothing now. 60 years old is nothing.
I think it's based on the lifestyle, genetics, and other factors.
Activity,
Activities,
exercise,
yeah.
balanced diet, modern
Yeah.
thinking, stimulation, you name it, it's very common. Thank you very much.
Thank you very much.
Important topics.
Thank you
And
very
the polypharmacy. We thank you, seriously. Ever young.
Thank you so much, Professor Charlotte, for the speakers, for interesting and stimulating talks. Thank you, Professor. Thank you so much. And now we will proceed to the next session. And it gives me a great pleasure to introduce the chairperson, my dear colleague, Dr. Hussein Omar. He's a consultant psychiatrist at the American Psychiatric Center in Neurology in Abu Dhabi. Dr. Hussein, he joined the American Center from St. George University Hospital in London, where he had his career there for more than 17 years. He has a rich bio. I will just pick up a couple of things. He is a strong proponent of the holistic approach to treating psychiatric disorders. He has a master's degree in psychiatric research from Institute of Psychiatry at King's College London, and he has numerous publications, international journal, and he is leading currently the ongoing scientific activity among the mental health care providers in Abu Dhabi through Abu Dhabi Psychiatric Club. Please welcome Dr. Hussein.
Good evening. Thank you, Dr. Mufid, for the nice introduction. I'm very happy to see familiar faces here. And I'm very honored to chair this session. I can see, obviously, it's 5 o'clock. People had a long day. But I think we were quite lucky to have this session, because I think it was put up very nicely by the organizers. If you look at the 3 sessions, you will find the theme, which connect the 3 sessions together. So the first session will be by Professor Mohandas. And Professor Mohandas, he has been in psychiatry for more than 40 years, with impressive CV, more than 1,000 presentations nationally and internationally. And he has won more than 40 awards in psychiatry. And he will talk to us about psychiatry rehabilitation through the lens of neuroscience. So he will show how we can use the most recent findings in neuroscience to inform our clinical practice from a holistic approach. Because as we know, in psychiatry, we do not just stop at the stage of symptom resolution. Our aim is to improve functionality, improve psychosocial performance, and for patients to achieve their full potential. So Dr. Mohandas will take us through this journey of how to help our patients with severe enduring mental health to maximize their potential through different psycho-rehab techniques, which is evidence-based and based on the most recent advances in neuroscience. And then the second journey, or the second session, will be about Dr. Matter's approach to schizophrenia. So in the first session, we'll talk about a journey about a patient. Second session, we'll talk about a journey of a psychiatrist in mental health. And the third journey will be a journey to the future, about how we use and integrate digital technology in improving our patients' care. So I have all the pleasure and the honor to produce our first speaker, Dr. Mohandas. The stage is yours.
Do you have a slide changer? This one, no? Okay. This way, no? Your operation is like this. Forward, fine. Okay, fine. I think good evening or good afternoon, I don't know what I have to just spell out. Thank you very much, Chair, for introducing me. As you have rightly told, I have already completed 43 years after my post-graduation. And somebody in the previous session has told that 60 is an old age. I am 70. I am 70, still kicking. All right. Today I just thought of people are talking about psychosocial rehabilitation, but I thought that what is the neuroscience behind all the therapies that we do have? No financial disclosure is no assistant for this presentation. I was speaker for many pharma and many of the organizations, especially WPA, CANP, ECNP, etc., since so many years. The learning objectives, what is psychosocial rehabilitation, objects and techniques, what is the training-induced neuroplasticity, and the brain areas involved in that, and what is the evidence for beneficial effect of psychosocial rehabilitation techniques that you employ. You know pretty well, psychosocial rehabilitation focus on one hand on the symptom control, and you instill hope, optimism, and self-determination for what? For a better quality of life, wherein you have to impart cognitive skills and social skills, and what is for that, you have to maintain a better health, even physical health of the client. You have to educate them, and vocational placement is needed. These are the crux. So better social interaction, better skill development, better family and support system, a better psychiatric and medical support, spiritual balance, better education and employment. That means adequate functioning if possible. The prominent rehabilitative techniques are reduction of symptoms or relapse, basically family-based intervention, and CBT, usual symptom and symptom-focused intervention, and improving social adjustment through social cognitive and neurocognitive strategies, that social skill training, neurocognitive remediation, and vocational rehabilitation. The techniques employed are psychotherapy, including CBT, and your family therapy, neurocognitive or social cognitive treatment, physical exercise, environmental enrichment, diet and nutrition, meditation, yoga and spiritual practices, and music training and vocational training. The neurocognitive treatment is remediating information processing disturbance, that is neurocognitive remediation. What does it achieve? You will focus on attention, memory, and problem solving. And you have got social cognitive treatment, focus on remediating impairments or deficit in how uniquely social information is processed. Social skill training emphasizes teaching concrete skills used in social interaction. Also, emphasize interpreting other social cues, their emotions and thoughts. There are targeted treatment in emotional processing and affect recognition. You can have micro expressions training tool, training in affect regulation or TAR, emotion management training or EMT. But many places, if there are no training, nobody follows that. Only the basic umbrella is followed. In social perception, you can have social cognition enhancement training, ACET. And focusing on the theory of mind, emotion and tone imitation training, instrumental enrichment program, and cognitive enhancement therapy. Comprehensive treatment, you can have combined everything together, social cognitive interaction training, that's called SCIT, or social cognitive skill training, SCST, or metacognitive therapy. Metacognition that it is not, it is almost like, where is metacognition? I will not digress it if somebody asks me, I will tell you. Integrated neurocognitive therapy. So, psychosocial rehabilitation improves neural plasticity. Basically, it's a training-induced plasticity. It improves the neurogenesis, that is new neurons, synaptogenesis, gliogenesis and angiogenesis along with genetic changes. Guiding principles of brain plasticity, I think everybody knows it. Our behaviors are the product of brain system, and feedback and action plasticity is being controlled from the top, and feed-forward connections are also responsible. I will not go into details about it, just touch and go. And progressive changes achieved through small learning steps enable ultimately large-scale changes, and substantial repetition and overlap in training are requisites for achieving the optimal change rates. Plastic changes link representation of serial events in complex behavior. Plasticity is controlled by neuromodulatory processes. Neuromodulatory machinery of the brain is also plastic, and plasticity processes are bidirectional. Now coming to the psychotherapeutic process, what happens? You have got a therapeutic relationship, and it involves attentional process, it involves empathy, both cognitive and that's called cognitive and affective empathy and theory of mind, social cognition, and it involves a mirror neuron system. Behavior therapy focuses on simple forms of learning, memory, and motor behavior that is associated operant, and brain structures involved are amygdala, basal ganglia, hippocampus. I'm not here to talk on which part of amygdala, etc. That is the functional neuroanatomy classes of mine that I will not go. I will just touch and go. And cognitive psychotherapy focus on specific pattern of information processing, basically on thoughts, assumptions and schemata, and evaluate, and you do the cognitive restructuring, etc. that's modified. Brain structures involved are basically neocortex, especially the frontal, that too also prefrontal, that too also basically dorsolateral prefrontal cortex and orbitofrontal cortex. Psychosocial rehabilitation improves attention, working memory, empathy, theory of mind, and social cognition. Now, basic terms, I will not repeat it. What is working memory, attention, speed of processing, verbal learning, and memory? I think most of the students would have had a basic idea. This is not this only a CME session. It's not a classroom teaching. And visuospatial learning and memory, empathy, theory of mind, and social cognition you are supposed to know. So I will talk about the attentional networks. There are alerting network is there, shows thalamic activation. There are different attentional networks. And you have got the orienting networks. It shows parietal activation, and you have got conflict network, which shows anterior cingulate cortex activation. And someone was talking about anterior cingulate when they talked about the neurology, psychiatry, etc. Anterior cingulate, especially anterior cingulate has got anterior, posterior, mid cingulate. This is the anterior cingulate, which is important. And especially working memory has got 5 components. Earlier, it was only 3 components. That's called phonological loop. It is basically lateralized to left temporoparietal region. Some of the areas which I have put it, the cartoons, you can see it. And storage component is Brodmann's area 40. Rehearsal component is Brodmann's area 6 and 44. And visuospatial sketchpad is another component of working memory. That is right lateralized. Basically, inferior parietal lobe, Brodmann's area 40 is involved. You can see from the cartoon area 40 where is it. Premotor cortex, especially Brodmann area 6. And inferior frontal cortex, area 47, and anterior extrastriate occipital cortex, area 19. Now we come to the empathy part of it. What is empathy? It is a capacity for the imaginative transposing of oneself into the feeling and thinking of another individual. That is the effective sharing between self and others. Also, effective sharing involves anterior insula. Insula is part of brain. It is put as anterior insula, mid insula, and posterior insula, superior temporal sulcus, amygdala, anterior cingulate, and areas of premotor cortex. And adopting perspective of others, that becomes part of cognitive empathy. And basically, frontoparietal cortex, ventromedial prefrontal cortex, medial prefrontal cortex, right inferior parietal lobule are included. If you want me to speak slowly, I can, but because of the time constraint, I'm going faster. And you can ask any question on functional neuroanatomy, anything, correlation, on psychotherapy or anything, at that time, if time permits, I will answer. Also, empathy involves self-agency and emotional regulation. The areas are involved are right temporoparietal junction, posterior cingulate. I told that not only anterior cingulate, mid cingulate, posterior cingulate is there, and the precuneus. And this is the affective perceptual empathy, basically right dorsal anterior cingulate, right anterior insula, right dorsomedial thalamus, and midbrain. Now, the cognitive evaluative empathy, left orbitofrontal cortex, left anterior mid-cingulate, and left dorsomedial thalamus. And the theory of mind, what is theory of mind or mentalization? It basically the capacity to mentalize symptoms, ability to recognize that someone else has a different mind from one's own. The inference is really derived from the facial expression, the tone of voice, and the non-verbal communication. The mirror neuron system is one of the concepts that we usually describe. Basically, it has come from the monkey brains, inferior frontal cortex. Basically, it is a posterior inferior gyrus. It was in the animal study. I don't want to talk of history. You can do Google search, mirror neuron system, Mohandas, you can read it. And lowest part of primary motor cortex, superior temporal sulcus, and inferior parietal lobule. This cartoon will describe the areas. Because if I just go further, it will be almost like a functional neuroanatomy class, which I don't want to. So there are overlaps of neural correlates. The theory of mind is a concept. Empathy is an expression. Mirror neuron system is one of the mechanisms by way of which we can explain. So the theory of mind, inferior frontal gyrus, empathy also premotor region of inferior frontal gyrus, mirror neuron system, inferior frontal gyrus. Empathy, you can see anterior cingulate, somatosensory cortex, and amygdala. On the other hand, theory of mind is almost like cognitive, superior temporal sulcus and inferior parietal lobule. Mirror neuron system also you can see parallel. So there's so much overlap in the system. But social cognition is perception of others, perception of self, and interpersonal knowledge. Everybody knows about it. I have finished with the basics. Now, is there any evidence for all these things? Evidence is there. You can see the violet, violet or little bit yellow. That's the perception. The green is attention. The almost orange is the working memory. And the blue is declarative memory and the cognitive control. This was analyzed, and we do have enough evidence, the neurobiological or neuroimaging evidence of these areas. And this is another cartoon. For example, a prototype, if you think of schizophrenia, you can see the medial prefrontal cortex. What does it do? Anterior cingulate and posterior cingulate, what does it do? Ventral striatum, what does it do? Superior temporal sulcus and medial temporal gyrus, what does it do? So what we do is, even with the cognitive training and this thing, you can change, you can really know the result through the imaging techniques. Evidence, several studies provides evidence for improved functional connectivity after cognitive training. That's important. That means neuroplasticity. And it improves executive attention, which is lateral prefrontal cortex and anterior cingulate basic ganglia, and draw on the dopaminergic system. Now, computerized attentional training and working memory training, the networks are involved in prefrontal cortex, which underlie both visual memory and fluid intelligence. There are so many techniques. The Cogmat fast forward word language test software, we do have many techniques. Then another one is cognitive remediation. It is associated with neuroprotective effects against gray matter loss in temporal brain region associated with cognition. You can see the references are there, some are in press, some are already out. The brain effects of cognitive remediation therapy in schizophrenia, structural and functional neuroimaging studies, that is usually the brain network's activation pattern normalizing towards the patterns observed in healthy control subject after cognitive remediation. Maybe due to, especially, it increased fractional anisotropy. Usually, we use this thing in the white matter changes. Okay, diffusion tensor imaging, usually fractional anisotropy index and the anterior part of the genu of the corpus callosum. You know, genu corpus callosum, it's a connection between right brain and left brain, if at all you think that. And corpus callosum has got so many subdivisions, that is genu, body, splenium, isthmus, anyway. Maybe due to increase in the interhemispheric information transfer between bilateral prefrontal cortexes via the corpus callosum. The reason is genu is more involved with the connectivity with the prefrontal area. Computerized cognitive training restores neural activity within the reality monitoring network in schizophrenia. That means there is improved medial prefrontal activity after training for 6 months. Now, neuroplasticity-based cognitive training in schizophrenia interim report after 6 months later, training-induced cognitive improvement is related to enhanced functioning after 6 months. A cognitive training strategy for first episode schizophrenia, you can have a bottom-up or top-down approaches. Bottom-up means initial training with simple sensory discrimination and processing tasks. Top-down approach, high-level memory process, reasoning, problem solving. Brain fitness program from POSIT Science that has significant, reasonably large improvements in global cognition, verbal learning, memory, and problem solving. There's something called mental and physical map training. That is mental training 30 minutes and physical training 20 minutes. The recent one is the integrated psychological therapy. After 6 months, this task improve many of the deficit that we are seeing in schizophrenia. Now, the recent one is a rehab COP. It's an integrative, this has come and published in 2019. Integrative neuropsychological rehabilitation program, 8 modules: attention, learning and memory, language, executive function, social cognition, social skills, activities of daily living, and psychoeducation. This has got a positive impact. Multifaceted approach, that's called SKIT. I will not go to because the time constraint. Physical exercise, you know what really the impact, I will not go into details. And cognition targeted dynamic and functional exercises. There are different brisk exercise. What is the difference between how long, how much? That must be another talk by itself. Music and dance is basically coupling between auditory and premotor cortices in musical context. In dance, kinesthetic and emotional perception, and it can improve empathy enhancing property and expressive skills. So these are all good. Music and neuroplasticity. The last one, spirituality. Many of the spirituality, the basic line, love, hope, joy, forgiveness, compassion, trust, and gratitude. Basically, spiritual practice of prayer, meditation, religious workshop, rituals, chanting, and yoga. If you want to read it, again, Google it, Neurobiology of Spirituality, Mohandas, you can get the article. And it basically it produces, especially in Insula and area 9 and 10, it basically changes are there after spirituality, that is experience-dependent brain plasticity. Can I use 2 more slides, the chairperson? Neurofeedback. Oh, sorry. I think it has gone. Okay. Neuro-religious experience. They have even a circuit involving dorsolateral prefrontal cortex, dorsomedial frontal cortex, and medial parietal cortex. Neurofeedback. You know very well, I am not here to discuss what is it can also improve. And targeted training modifies oscillatory brain activity in schizophrenic patient. I will not go into details, finished. Training induced plasticity of inhibitory control. And I think I have to stop here. I don't want to steal time. Thank you very much. And if you have got any doubt, I am here to talk on any functional neuroanatomy, neurobiology. I am here. Thank you.
Thank you. Thank you very much, Dr. Mohandas, for such a wonderful, of course. We will have a plenary discussion after the third session. So now, Dr. Mohandas covered a very important topic, which is the neuroscientific or the neuroscience basis behind psychosocial rehabilitation. And I think we have 2 gurus with us today. So the first guru, Dr. Mohandas, has 43 years of experience in psychiatry. And our next speaker, I think he has 46 years of psychiatry experience as well. Our next speaker is the one and only Professor Talat Matar. He is a professor of psychiatry at TRAC University. Dr. Talat is not only a psychiatrist, he's a thinker, he's an intellectual, he is an author. He has several books, he translated several books, and he also authored several books. He had lots of scientific papers in national and international journals. So I have all the pleasure and the honor to introduce Professor Talat, and I'm pretty confident that his ideas about evolutionary psychiatry will impress you. This is something he has started to develop a keen interest in, and I am as keen and as excited as you about listening to Professor Talat talking to us about the evolutionary aspect of schizophrenia. Prof. Talat, the floor is yours.
Thank you, Dr. Hussain. I'm here again. Thank you. I just want to admit that it's very difficult to summarize the thoughts of such a great man. We have a great psychiatrist who is not less than any pioneer of psychiatry, in my opinion. Freud, Jung, Eric Payne, all of these people. But unfortunately, because all of his production is in Arabic, it is not well known all over the world. But he's a very deep, he's a philosopher, he's a psychiatrist, he's a thinker. And I'm trying to summarize or to give just a profile about his theory in psychiatry. He has a school of psychiatry. Just I want to give you an idea about that. This is just to show you how great is this man. This is the CV. Wonderful CV. These are the scientific paper he published. And these are the essays in daily journals. And he was writing in literature journal, philosophy journal, scientific journal, and also in supervising thesis, master and the PhD thesis. These are his books, more than 55 books. in psychiatry, in literature, in philosophy, in criticism. Okay, this is just to show you how this man is. What I want to give you in this 30 minutes is to give you some ideas about his theory in psychiatry and psychopathology and psychotherapy. Some of his thoughts, he called it biorhythmic evolutional psychiatry. In the afternoon, early in the afternoon, we talked about the evolutional psychiatry. His evolutional psychiatry is different from the traditional evolutional psychiatry. He has own theory, which based on the idea of evolutions, but not influenced by our cultural, by religious, he was a Sufi as well. He was Muslim Sufi, and he is Egyptian. So all these modulated his own thoughts about evolution. He believed that mental health is not a single value. There is nothing called mental health. There are stages, there are levels of mental health. This is number one, which is he is unique in this definition. Nobody talk about mental health like him. It's not a single value, but rather several values or several groups of values, which it can be arranged in ascending level. The difference between these levels are necessarily qualitative and not just quantitative. It is qualitative and quantitative as well. Man is a state of constant development. He believed that man is not static. He is still in a state of continuous development, not only in his history as a species, but also during his life as an individual. And all the evolutionists say that, like, for example, Haeckel said that the ontogeny recapitulate the phylogeny. So we are during the embryo life, we recapitulate what happened during the thousands or millions of years in the creature. Dr. Rakhawi believed that not only that, but during our evolution in our life, we are recapitulating again and again and again. Every time we call it the evolutional crisis. The individual and his environment should be examined. We cannot define or cannot diagnose a person without knowing his culture and his cultural background. He accepted the definition of WHO, mental health, love, adaptation, work, adaptations, and productivity and satisfaction. This is the definition of mental health of the WHO, the work, satisfaction, and adjustment. He accepted that, but on what level? In different level of the people. He classified the levels of the people, or the mental health of the people, in 3 levels. The first level was his usual level, which most of the people live in, which he called defensive level. People adapted, and he has different defense mechanisms, and he is adaptive in this life. So what is his priority, this level? The priority will be, number 1, adjustment. Number 1, adjustment. All his goal is to adjust to the society and to be conformed with the society. The second priority is work. Work is something to earn money. For majority of people, work is something to earn money and to adjust to the society. But satisfaction is the least priority. Most of the people are not very satisfied, and they are not concerned about satisfaction. This is not something very essential for them. We are living khalas, Aisha. The other level, which he called insight, upper level, insight, intellectual people. People who are thankful, who want to interpret everything in the world, who want to understand. These people are intellectual. They use the intellectualization. The first priority for them, to be satisfied. He wants to be satisfied. He wants to know where he is, who he is, where he come from, who is going. So he's always reading about religion, reading about literature, reading about philosophy. He wants to know where he is and who he is. The second priority for him is adjustment, to adjust to people and society. And the least priority is work. But the creative level, the third level of people who are creative, people who are the leading of this world, the leading of the civilization, the first thing of them work. Work is not just a job. Work means that production. They need work is the main goal of theirs to change the world. Yani their aim, not only to understand, not only to be intellectual, not only to be inside, but to change the world. Then satisfaction, then the adjustment is the least priority, and most of these people are not adjusted well to the society. Most of them are easily, not adjusted, not easily accepted by the majority of people. Most of the leaders are like that. Most of the thinkers are like that, as we said. Here, he said that always we are in oscillating movement between the three levels. It is not a statistic one. You can in the defensive level, and sometimes you jump to the second level, the intellectual level, and then the third level, which is the creative level, and then you come back and fro, back and fro. And he always say that we are always doing this movement, but the normal growth is to grow from the defensive level to the creative level. But during this growth, something always happening, which is the evolutional crisis. Evolutional crisis. When you jump from a level to the second one, you might have some abnormal behavior, and he denied and he does not accept to call this a psychiatric disorder. This is not a psychiatric disorder. This is evolutional, which we see always in the adolescent stage and people in the midlife crisis when they change from area to area. But if the path is not normal, if the path is not easy, and if there is a parade for this growth, this is the mental illness. So the mental illness in his thoughts, the failure of the growth, the failure of the, so all the mental illness, and Dr. Rakhawi believe that it is aborted growth, aborted success, aborted creation. So if we go from the defensive level, for example, to the creative level, there will be growth crisis, and this growth crisis, if you pass it well, you will go to the second. If not, either you come back or you go to at this show. If you go, either you come back or you go to the other level, or you fill in psychiatric illness. And he has very nice classification of psychiatric disorder according to these steps. So, if you want to grow to another level, and you have lot of defense mechanism either be adaptive or crippling. If it is crippling, will keep you status quo. You will not move, and this is the static person. And most of the personality disorder people are like that, or neurotic people. Neurotic people use a lot of defenses, and personality disorder people also, they have a siege or a wall of defense mechanism, and they will never grow to the other one. But if you want to go with insight and start to know what's around you, and some defenses mechanisms are dissolved, and you cannot solve it, you can go to depression and frustration, okay? But if you want to live to the creative level without having the full adaptive abilities for that, this is the disintegration, and this is schizophrenia and psychosis. So psychosis is abortive. Very similar to what we said in the afternoon, and this is explain why many families which have schizophrenic people are artistic and creative people. His theory is called biorhythmic evolutional theory. الطب النفسي الإيقاع حيوي. الطب النفسي الإيقاع حيوي, or biorhythmic evolutional psychiatry. It is a complex hypothesis, a series of hypotheses stemming from long clinical practice that can be considered as product of phenomenological method, neither introspective nor experimental. He always criticized Freud and his follower. Freud started as a clinician, okay, and most of his ideas, the primary ideas of Freud, was based on clinical practice. But when he went on, he went apart from the clinical, from the patient, and he became theoretical and introspective, okay? But he, Dr. Rakhawi, he used to claim that his theory stemmed from the clinical practice, and that's all. That's why he did not write about his full description about his theory until 1 month before his death. He died on 18th of December last year, and 3 months now. And all the time we were asking him, when you will write down your theory, he used to tell us it's still evolving, still information, okay? And I remember the last before his death, 1 month, he died 89 years old, and just 25 days before his death, he gave a lecture online, 3 hours. 3 hours continuous, talking about the sexual disorders and the meaning of sexual relationship in evolutionary manner. And when we asked him when he would write down this, he told that, inshallah, it is still in process. The basic concept of his theory is the human being is at least a brief history of its kind. That is, represents and carries its evolutionary history in its ascending order that it includes in the newest and oldest without canceling one. And we are recapitulating our history million years ago from when we were just a monocell until we became a human being. All this is restored in our brain and is still active in our brain. The brain is not a container of information, but a vital material, permanent information that's shaped by more information through activating the existing, like the previous lecture told us now how it is, our brain is elastic and plastic and is growing. Mental illness is a natural phenomena. هي دايما كان يقول لك هل يعرف أحدكم ما يحمل داخله من جنة؟ يعني all of us are inside us are potential to be psychotic, and we are always psychotic. How? During sleep, when you dream, is this not psychosis? You are hallucinating something disconnected, at all disconnected, irrelevant. This is the psychosis. So we have the right to be psychotic. We have the right to be psychotic, and we got this right during sleep. So he said that the psychosis is a natural phenomena, and only it appears when it is restricted and when we cannot let it go in its natural path. The main ideas of behavioral psychiatry or this evolutional psychiatry based on Charles Darwin's On the Origin of Species and Ernest Haeckel Ontogeny Recapitulate Phylogeny. The process is not just a summarization in the sense of briefness like Haeckel said, but no, it is a repetitive, open-ended. All the time we are repeating the cycle so that the circle does not close, and the difference in the time unit, meaning that what was done in millions, perhaps even billions of years, is repeated during the life of the human being, or ontogeny, and summarized as the regained phylogeny. Microgeny, he talked about the microgeny, which this is one of the differences between the traditional evolutionary psychiatry and the rhythmic psychiatry of Dr. Rakhawi, is the microgeny, is the moment of the creativity of thoughts. Recapitulate macrogeny, developmental crisis, which recapitulate the ontogeny, the growth of the whole individual, which turn restore the course of phylogeny. And now I'm sure that you will not get me well because, as I told you before, very difficult to clarify his thoughts. It needs hours and hours, maybe days, to clarify exactly what you want to say. And rhythmic cycle is a creative restoration that serves the evolution unless they prevent alienation or denial where the psychiatric disorder occurs. So here, what I told, the ontogeny repeat the phylogeny, the macrogeny repeat the ontogeny, and the microgeny, the moment, repeat the microgeny. And this is the apportion of any of these will cause the psychiatric disorder. He does not believe well in the nosological classification as DSM-5 or the ICD-10, but he takes them as something to have to accept for teaching purpose and for communication, but he never admit or appreciate any of them. He said that we should focus on the human being, not on the disease. So his diagnosis called structural diagnosis, not clinical or nosological diagnosis. Structural diagnosis is the most important. What the benefit of the patient if you tell him you are depression or schizophrenia or phobia? No, whom you are, what is the structure now, where is your levels of mental health, and how the therapist will deal with this. So BAP started from the clinical practice here and now, identifying patient primary from diagnosis, but rather through the structural psychopathology that indicate the diversity of kinetic charges of the brain that represented the development of the post-phylogenic and ontogenic. And he always see people, when you come to him in the clinic, this is not his own idea, this is the idea of Byrne in the morning, who tells that when you see a patient, you see a forest full of all animals, or a playground full of all the creature, and you are the maestro. The therapist will be the maestro who will submit this and who will give this rule to this and all. So he was always like that. And this is some of the differences between the traditional evolutional psychiatry and Dr. Rakhawi biorhythmic psychiatry. Here they say that we are mainly have three brains: the reptilian brain, which is concerned with the biological function, and the limbic system, where there are emotions, where there are some behaviors, and I think this is the core of the psychosis and psychiatric disorder, and we have the neocortex. And when the patient comes to you, one of them is always prevailing, and the role of the therapist is to suppress and to encourage some of them. He gives other names and make it more elaborative. He said that we have primitive archaic brain, then or a schizoid brain that has no object at all. The embryo in the uterus has no object. Okay, this is a primitive archaic brain. Then when we go outside the uterus and so you see the people, this is a depressive, the paranoid phase. He is affected by melanocline, the object relation theory of melanocline, and this is he is a flight brain. And the next one, the more developed brain, is the depressive brain. But which one? The depressive dysphoric brain, which is not creative depression. And then if we succeed in tolerating this stage, we will go to the depressive tolerant. And he believed that the top of mental health is to tolerate depression. And the real people should be depressed, because we don't know where we come from and where we are going to. But not frustrating depression, motivating depression to go after. Then the last one, or the top of the brain, is the dialectic growing relating brain, or the creative brain. I think this is the same. What is psychopathology? In order for life to continue with proper efficacy, all these levels must be organized momentarily by itself in oneness, no matter how different the charges. Yani you have many brains, you have the reptilian brain active, or the limbic brain, or the neocortex. All of them must be in harmony. This is the mental health. يعني طبعا very similar to if you remember Eric Berne theory, the child ego state, parent ego state, the same idea, and should be in harmony. If the content is turbulent, overlapping, and rigid, the unfolding is unable to perform its basic function by adding the latent to the actor, dialectically or creatively, but his push will be the random activation of huge amount of confused content without sufficient opportunity for assimilation or repression, which result in explosions in the form of mania and aggression or excited behavior, or disintegration in the form of schizophrenia and psychosis, or retreat in the form of depression, or closure insight in the form of personality disorder. This is how he classifies the psychiatric disorder. طبعا he believes in always we are in 3 stages of existence, اللي هي normality and crossroad, then creativity. And he believed that everybody is creative, even the child. And when the creation itself is not the production of literature or music or no, creation in life, how to create your everyday life. And the creation also during dream, sometimes we dream we are creative, but he believed that when the normality is so severe, so that you have so mental mechanism, this is the extreme normality بيسميه فرط العادية. Which Sartre called them the مش عاوز اشتمهم يعني الأندال يعني أو the rigid stagnant people. And if the extreme of the creativity will be the madness. This is the 3 states of evolution, and we are always in the biological rhythm. What is psychotherapy in Dr. Rachawi school? Biorhythmic psychiatric begin with understanding the meaning of symptom. Number 1, the meaning. Every disease has a meaning, have a goal. He wants to say something. And every symptom has a meaning. The language of the disease. This is what the disease says. And also, what did the patient say through his illness when he fallen? This working on saying. So we have to understand what the people want to tell. The depressed people say to, please keep away, I am weak. Please keep away, I am useless. Man, this is what the depression said. And the manic says, please take care, I am the most powerful person here. And the schizophrenic people, what he say many things according to the symptoms he has. Biorhythmic psychotherapy is to complete the extension of the gross impulse, either to push the patient to the 2nd stage or to postpone it and to keep it. And he always blame the abuse of antipsychotic medication of the doctor because they always keep the patient in a stagnant position and they prevent him from the chance of the gross. Okay, so he always give antipsychotic in time and in proper doses, and always give a chance for the patient to grow, not to keep him stagnant. And we are very happy that our patient, alhamdulillah, no hallucination, no delusion, alhamdulillah, he is not aggressive, but he is not a man. He is not a man. Even he is not an enemy, he is just something, okay? Integrative psychotherapy is containment of contradiction to contribute the keeping peace. Containment of contradiction to continue keeping pace with the redirection of the gross. Maybe he went to the wrong path, so we direct him through psychotherapy, through milieu therapy, through group psychotherapy, through activity therapy, and all these types of therapy are in his hospital. Yani he doesn't believe in only in individual. There is individual psychotherapy, group psychotherapy, and milieu therapy, and work therapy. Just to redirect the energy or the path of the growth. The philosophy of psychotherapy, the human brain is multiple brains, as I told you. The human brain is a zoo of neighborhood, okay? Hierarchical, reciprocal, and continuous. The individual consciousness is not individual. There is nothing called consciousness. Consciousness means that relating to somebody. You remember if we talk in the afternoon about the social brain. So our brain is a social, okay? Even if there is no other, there is always other. So he classified consciousness into interpersonal conscious between me and people, collective consciousness in the group or in the society, cosmic conscious, its relation to the cosmos as a whole, absolute conscious, low below cosmos, people who are spiritual, to the unseen to him. He was a Sufi, and him means Allah. Okay? Which continuously with the vital pulse and rest day and night, all of this stems from the reality of the deeper culture of perception and man's relationship with his origin, beginning with the universe, an extension and its vibrant, creative, communicative phase. This culture is implicitly responsible for the emergence of this theory in the first place. And he believed that his theory originated from his culture, from the Egyptian culture. And always he said that Egyptian school, always he used to say it as Egyptian school because it stemmed from the culture of the people. Intersexuality in psychotherapy, or intertextuality, he was a critical in literature. He has many essays and many books in the criticism in literature. He also believed that the human being is a text, and we have to look at it as a text, and we have to criticize it. Okay? So every text is an intertext, and there is no text alone. There is theory in literature. If somebody is interested in literature, there is something called intertextuality. There is no text by its own. All the books or all the texts are mixture with other texts or having ideas, including ideas of previous texts. So also the human being is taking ideas from his ancestor. Every human text is an intertextuality. The human being is a text that need reading. In psychiatry, we present the human being as a text subject to criticism as a multiple entity that is generated here and now from many texts that are not only accompanying here and now. Psychotherapy is intertextuality through rumination, absorption, dialectic approach. His psychotherapy school is called MMM, المواكبة والمسؤولية والمواجهة. المواجهة والمواكبة والمسؤولية. He accepted the acceptance commitment therapy with the third wave of the dialectical behavior therapy, but he agreed with them that psychological pain is normal. Pain and suffering are two different states. You don't have to identify with your suffering. If you accept your pain, you get rid of suffering. But he always criticized that it is intellectual and not fit for seriously ill patient. But his school is confrontation, togetherness, responsibility. Psychotherapy is to keep up with the process of growth, which is carried out by a responsible person with experience, awareness, continuous personal, to other men which need his help, removing obstacles to the march of the path of the possible, or delay its pulse, or modify its course, or sip its reflection. Confrontation means that confrontation, acceptance, determine causality to teleological causality. In the psychoanalytic schools, why this happened. But in his school, we don't ask why this happened. We ask what that mean. Then after what that mean, then what? Then what after? Why not to dig in the past? No, let us try here and now and go forward. Confrontation with self, with reality, with other, to break the unadaptive mental mechanism and to enhance the adaptive mental mechanism through dealing with defense mechanism with caution. Consider timing and dosage, symptom prescription. طبعا he talk about symptom prescription, which is another lecture. Then togetherness, limit verbalism, refuse to generalization. There is nothing called الإنسان يبغي كذا, لا. You and me, here and now. Use para-verbal language, the movement, body language, the ability to regression to the level of the client, focus on the here and the now, acceptance of the mutual criticism. I am also growing with the patient. I am not only teaching the patient, but I am also growing with the patient, and then the patient to criticize me as well. The responsibility of the therapist consider local culture, parental attitude, and this is different from all the other themes of psychotherapy. The therapist have parental attitude. He should say yes, no to the patient and to the family. The responsibility of the patient. The patient is always responsible for his illness. The acceptance of dependency in a positive way. The quality of training and supervision upon the therapist. And at last, the role of the drug. Was he using drug? Yes. But he believed that drugs, they use in hierarchic level, so to suppress the old brain. And this is also very biological because dopamine 2 receptors are abundant in the limbic system more than in the frontal lobe. So if you give antipsychotic, we are suppressing the older brain for the favor of the new brain. And the benzodiazepine work in the frontal lobe. So we are suppressing the new brain to give a chance to the primitive brain to express itself. And this is what his thoughts. And I'm sure that Mr. Chairman is will be upset. So I will finish here. But let me just give me the last, his will before he dies. And he wrote this will in one of the journal. Those who truly miss him must continue what his departure did not allow to complete. And those who received some of what he did, not say must continue better than him in giving him and the creativity. He also recommends that no one believe what I say until he prove it, as he must review it himself again and reform with criticism and update. Thank you very much.
I thank Professor Talat for such a wonderful and informative lecture or talk. And now we're going to talk about another journey. So the first talk was about the journey of a patient from symptoms to recovery and then to rehab, underpinned by the most advances in neuroscience. And the second lecture by Dr. Talat was about the journey of a psychiatrist or a clinician from clinical practice, training, to a level of knowledge and experience to develop his own thoughts and theory about schizophrenia. Now it's a journey which is very exciting into the future. We all agree that digital technologies is gonna transform everything. And mental health is not an exception. So the use of digital technology in mental health has been there for only a few years. And luckily, we have an expert in this field who has been using digital technology to improve and increase quality of mental health services. So let me welcome Professor Dr. Sandeep Vohra. Dr. Vohra has been working in psychiatry for at least 25 years, and in the last 12 years, he has managed to integrate digital mental health services in his practice. He has more than 1,500 TV appearances. He is using his potential or his work to increase awareness about mental health. He has been featuring on various magazines, and also as an entrepreneur, he has been selected or nominated as one of the 25 dominant leaders in healthcare industry. So without further ado, I would like to welcome our speaker, Dr. Sandeep Vohra. The floor is yours.
Salaam alaikum. I must thank Chairman sir for giving my introduction in such a nice way. So let me share with you my journey is, I was just seeing the date today, it's 6th May 2023. And my journey into digital mental health started actually exactly 20 years back when I had the opportunity to meet the greatest scientist of the country, Dr. Abdul Kalam. And I was lucky enough to meet him at the President's house. And the date was 8th May 2003. The thought of digital mental health started in me long back. And then when I had an interaction with him, it was a 45-minute meeting with the great man. And I said, sir, we have launched INSET 2B at that time. And I have been told, I saw on TV that, we can reach the masses. So why can't we do it for the mental health? So he was very appreciative of my concept. And he said, and at that time I'd made a CD and presented it to him under my NGO, Project Sahyog. So I was just remembering that God has been kind that, what I shared with that great man, we can, gradually we are progressing towards that. And it was a real encouragement from him. And then I started the journey alone, and gradually we never thought that digital revolution will take place in such a way. So let me start. Let me set the context. So I'll just tell you what will be the flow of my presentation. Wait a second. This one. Okay, so first I'll be speaking about the challenges due to demand-supply gap. Then why digital mental health? Then what are the services desired at various levels? And why integration into general hospital we are talking? Because if you see the original title on which topic which I'm speaking is integration of mental health services into a general hospital setting. And what is the process of integration? It covers both preventive and curative aspect. And what is the conclusion? So let us, for the context setting, let's see what are the challenges due to demand-supply gap. If you see the World Mental Health Report last year's, the problem statement for the world is that we have widespread mental health problems and 1 in 8 live with a mental health condition. Most of these are undertreated. 71% of the people with psychosis do not receive mental health services. We are under-resourced. That is 2% of the health budget on average go to the mental health of the full health budget. Since I am focusing on India, so problem set for India, if we see, India has one of the highest rates of mental illness in the world. And according to the National Mental Health Survey 2016, nearly 14% of India's population required active mental health interventions. 56 million Indians suffered from depression, 38 million Indians suffer from some anxiety disorder, and 20 million Indians commit suicide every year. India's hidden mental health problem, if we see, 1 in 5 Indians will suffer from depression in their lifetime. 48% private sector employees have a general anxiety disorder or depression. 150 million people across India are in need of mental health care interventions, both long and short term. 46% private sector employees report extreme stress as a result of their work. This is very interesting. This is by Government of India for the first time post-independence. If you see, it is Ministry of Education, Government of India. It's a last year survey. It's a mental health and well-being of school students. If you see, the class 6 to 12th, and it covered 28 states, 8 union territories, 1.9 lakh boys, 1.9 lakh girls, 9 lakh girls. Total 3.8 lakh students were surveyed. and you see the degree of problem, that percentage of students' responses on aspects of mental health, you see 84% said that they had the responsibility of doing well. 81% had causes of anxiety, such as studies and exam results. So, in nutshell, this is the first time Government of India has taken up a survey of this magnitude, which covered all the states, showing the degree of problem for students. Let's see the mental health at workplace. If you see this, first I was talking of India, now if you see globally, 60% of world population is in work, 61% of workers work in informal economy, 207 million unemployed people are expected in 2022. The prevalence, if you see, 301 million people lived with anxiety in 2019, 280 million people lived with depression in 2019, and around 7,03,000 people died by suicide in 2019. 15% of working age adults had a mental disorder in 2019. And if we see the impact, 50% of total societal cost of mental health condition is driven by the indirect costs such as reduced productivity. 12 billion working days are lost every year to depression and anxiety, and $1 trillion cost to the global economy due to depression and anxiety, predominantly from lost productivity. I hope such slides are seen by the policymakers, not only of India, but for the world, to see how important it is for us to generate resources and look out solutions for mental health. And if you see the financial loss, then according to WHO's 2019 estimate, economic loss from mental health issues in India alone will be over $1 trillion between 2012 and 30. Poor mental health among employees costs India employers around $14 billion annually in absenteeism, lower productivity and attrition. And if you see, 33% people contribute to work despite poor mental health. 80% Indian workplaces reported mental health issues during the past year, and 39% affected people, despite the alarming signals, prevent taking steps to manage symptoms. And overall, India accounts for 15% of total mental health burden. If you look at the mental health workforce, so per lakh population, see, we have psychiatrists 0.29, nil child psychiatrists, other specialist doctors 0.15, mental health nurses 0.8, psychologists 0.07, social workers 0.06, occupation therapists 0.03, speech therapists 0.17, 0.36 are other paid mental health workers. This shows that there is a gross shortage, and the gap between demand and supply is huge. And if you see the infrastructure, there is lack of infrastructure. If you see, the prevalence is 2,443 per lakh population of mental disorder in India, and there are 43 mental hospitals across the country with a combined bed capacity of just 20,000, and annual mental health expenditure per person is just Indian rupees 4. This was before pre-pandemic. If you see, after pandemic, the estimated additional 53.2 million cases of major depressive disorder and 76.2 million cases of additional anxiety disorder. Basically, average 25 to 27% of increase. Now, with all this demand-supply gap, why are we talking of digital mental health? So, if you see, the benefits of digital mental health services, the clinical efficacy can be similar to existing therapies. Mass precision and personalization of services is possible. Less exposure to stigma and discrimination. Data-driven and outcome-focused decision-making. It promotes equitable access, focuses on prevention and early treatment, integrates into health systems, need-based services, improves population data, quality and quantity, and enables self-determination. And if you see at the top, increase accessibility, availability, affordability, and scalability, greater satisfaction through consumer empowerment. So these all issues tell us that this is the only way forward for us. So what are the digital mental health delivery options we have? So we have mental health apps, we have online therapy platform, we have telepsychiatry, which all of you are aware and using it. We have mental health chatbots, we have digital therapeutics, online self-help programs, and online support groups. Now, what are the service, if we use digital mental health, what are the service demands at various levels? So if you see this World Health Organization recommended this pyramid. So the services of mental health, if you see on the left side is the pyramid, and the right side is the color code I've used for degree of the problem. So from high to low, the long stay facilities and specialist psychiatric services under the formal services would be in general hospital, community mental health services, and primary care mental health services. Then in the informal sector, we have informal community care and self-care. So why are we talking of integration into general hospital? See, so I have actually used the WHO's last year's report, and why are we interested in integrating it into general hospital? So this is the chapter Restructuring and Scaling Up Care for Impact from WHO's last year's report. And this is chapter number 7.2, Mental Health Integrated in Health Services. So it says integrating mental health into general health services is a crucial ingredient of mental health reforms. Why? Because it helps to increase access and reduces stigma. It means physical and mental health problems can often be treated simultaneously. It also makes mental health services much more accessible because general health services are usually closer to where people live. If you ask somebody who has a problem, you say that you come to a psychiatric clinic, there's a taboo. But if you say, okay, you are going to that hospital, you can meet that doctor there, the taboo is much less, and of course, the person is also very comfortable. Therefore, integration advances universal health care. So, general hospitals have a multifaceted role in mental health systems, which may include outpatient care, short-term inpatient care, support for non-specialists, support from long-term care, and licensed psychiatric care. And the hospital which I'm going to show you has mobile teams also for community-related work. So, with this theoretical concept, we thought of integrating it from a preventive and a curative aspect. And how did we go ahead? I would like to share it with you. So, this is the hospital. One of the largest hospitals in New Delhi. So the name of the hospital is BLK Max New Delhi. It's the largest private sector hospital in Delhi. It is spread over 650,000 square feet. It's 650 bedded, 125 critical care beds, and 117 state-of-art modular 17 state-of-art modular operation theaters. Why I'm highlighting this is because it has taken me 4 years to enter in this hospital because psychiatric importance of emotional health, I had to deeply dig in the brains of the management. I kept on requesting that emotional health is very important. Finally, after 4 years, we were able to integrate in such a way that it is acceptable. And you will be surprised to know that management is actively cooperating for integrating it, and how, just I'm going to show you. So the services which we are giving here are screening services, counseling services, and pharmacotherapy. So basically, from prevention to cure, we are covering up everything here. And the mode is both online and in person. That is, it's a hybrid type we are giving. So the digital preventive arm, what are we using? So this is a concept, Emotional Wellness Index. It's a front-end technology team developed by me and my digital team. It delivers a rating scale. It's like any other screening questionnaire, which you have gone through, you have used yourself many times. So it's one of the screening questionnaires. And in this, we have a color coding. Color coding, which means that if somebody comes after, it's a questionnaire, after you fill it up, digitally you get a response. Green color means you are normal. Blue means there is mild emotional disturbance. Yellow means there is moderate. And orange and red means it's severe. Not only does this Emotional Wellness Index explain the overall stress, but it also tells us from which area of our life the stress is emanating. Whether it is circumstances, whether it is domestic life, whether it is nature, clinical symptoms, or professional life. So this is how the color coding of the report comes. Once a patient fills up the performer, it's all digital. The digital process is we send a customized link mailed to the organization, in this case BLK Max Hospital. The link is mailed to the HR, in this case to the management group, which forwarded to employees, in this case the patients coming to the whole body checkup. There is acceptance of terms and conditions to take the assessment. Each participant then registers with basic details, responds to 55 questions. It's a questionnaire on 7-point Likert scale. Post-completion, automated report is generated for the specific employee or patient, and result of full participant is compiled by us for group analysis. A consolidated and detailed group report is shared with the organization. So the most interesting aspect which fascinated and made them agree the management was that it is an automatic triaging format. For people coming in green, we suggest yoga, pranayama, meditation. For mild group, we tell them to have few sessions with counselor. For moderate group, we tell them multiple sessions. It's a screening questionnaire, so it is not for the patients. It is for people coming to the hospital for general checkup. For severe and profound, we tell them multiple sessions with psychiatrist. The sample report comes like this. So whosoever fills up gets a report on its email, which is like this, which indicates the level of stress. And then, if you see, then the domain-wise analysis, which I was telling you. So if you see this, the blue color domain-wise analysis, it tells from where the stress is coming. So nature, circumstances, blue and yellow are the ones which are mild to moderate. And then it has automatically the suggestions which are written and emailed to the person who does it. So this is how a group report comes. So if there are multiple people, then what we do, this is a group of 100 people, 102 people we did, and this is how a group report appears. And the group report is seen by the head of the organization or the management group, which decides, and they get an idea what percentage of people have in that group have a problem, how many of them require services, mental services, and how many they don't require, so that they can take the appropriate action at their level. So this is the executive health checkup program. So now you in your hospitals, on all hospitals, we have an annual checkup or executive health checkup in which the patients come, they get all the body blood tests done. So what we have done is we have told them that emotional health is a value-added services. So amongst all the tests like blood sugar, blood urea, for the whole body checkup, they add this emotional component, and that is where this is how it looks like. So we tell them, they fill up, and based on that report, besides the recommendation of whether you want to go to a cardiologist or a gastroenterologist, we suggest them whether they require mental health services help from a counselor or psychiatrist sitting in that hospital. So this is with the hospital, the report is co-branded with the hospital so that the person who has come there understands that this is the hospital which is giving them the report. Now, this was the preventive arm. Let's see the curative arm. So curative arm means we are using web application and online therapy. So this is an app we have by the name of Relax Now, and this is the website we use. Nobody No Tension Healthcare website. So basically what we are trying to do is we are utilizing the digital tracks to cover up anything and everything for that hospital. So if you see this, we have 6 levels. So if the hospital says we want only screening, digital screening, we provide only, that is level 1, only screening. If they want only counseling services, we tell them, okay, we will give you the counselors who will do only counseling. If they say, okay, we don't want any of these, we want only the psychiatric treatment direct, so we give them the medical intervention only level 3. And many times we have a combination requirement. Some organizations want a screening as well as counseling. Some require only counseling or drugs, and some require A to Z everything. And whatever we provide, it is both online as well as in person. So it's a hybrid model. So this is our first pilot, and since it has become a hit there, so what we are planning further to integrate it completely is that we are planning to, the first step, the executive health checkup I've explained, we are planning to utilize hospital website for screening as well as solutions. We are planning to use this digital arm for all indoor patients of that hospital. We are planning to use it for all OPD patients. We are planning to give it to all accompanying relatives and attendants. We are only at stage 1 at this juncture, but ultimate plan is, depending on the success, we are going to, first we will have to persuade the management. At this juncture, they are quite happy with the response. So I believe that we'll be able to cover up all the other steps from 2nd to 5th. So these are few of our researches and publications. If you see the second title, this is measuring reliability and validity of stressometer. This is where we have done a screening. We have actually published it in Indian Journal of Psychiatry, the whole concept of emotional wellness index. And this, in which we have done, this is, we have actually done research with Houston University, USA. Then we have used this concept for the armed forces. If you see the paper entitled Finding the Enemy Within, Combating Stress Among the Indian Paramilitary Forces, we used we took the permission of the DG of an armed force of India, and we were able to screen around 450 constables, and then we analyzed and gave them the report which I've shown you, a group analysis report, and at that time, it is pre-pandemic, around 37% required help, the armed forces. So this we have published. Then we have done the same screening for medical students and professionals in one of the medical colleges. Besides this, we have done the same, if you see the last, addressing stress among nurses in India. So the conclusion from my point of view is that experience shows that it is possible to provide quality mental health care in general hospital settings, and this can complement other community-based mental health services. We agree with this concept and have been able to start implementing it successfully as a digital mental health vertical of a leading multi-specialty hospital in New Delhi, India. Thank you. I think Chairperson would be happy. I've just covered up for the previous speaker. Thank you. My pleasure, sir.
So we reach the end of our sessions. And now it's talk time, or question time, I mean. So if anyone is keen to ask any of our speakers a question, please, that's your time. Any questions for our speakers? Yes, please.
Good afternoon. Najm Al-Falahi, London.
Yes, just more close to your mouth.
Closer? Yes. A fascinating session, really. I am so happy. The question for the last speaker. Your application, your work is excellent and can be applied to so many areas. Why did you choose a hospital? Why not a working place for the first time?
I understood the first part. Achha.
I think the hospital.
Okay, sir.
Verified.
Sir, we have been using it not only in hospital, we are using it everywhere. We have actually approached various organizations, which corporate sector, we have approached schools, universities, and the hospital has been my primary reason for being is I'm myself attached to the hospital and I'm visiting consultant there. So it was easier for me to convince them about the importance of emotional health, and that also on a digital platform. Because you know, all of us face this, that people are, the management of the hospital is usually interested that, okay, whatever gives them good amount of money. So they perceive mental health as not a revenue generating arm. So that became a challenge, so that is there. But we are actually making it community based. So the digital arm is, from our side, we are actually, I've just shown you one part of the whole concept, but we are covering almost all the organizations, and many are in the process, and we are in the process of giving the services to many corporates in the country.
Can I have a question to Professor Motar? Prof, a fascinating lecture. What are you going to do next?
What are you going to do next, sir?
Always presenting a challenge,
the next
isn't
step
it?
is to write a book about Dr. Yahya Al-Rakhawi and his work. This is which we are working on now. And they want to elaborate to the people. There are Arab thinker as well, and there are Arab psychiatrists as well, and the world is not listening to them, maybe because of lack of communication, and most or 100% of his production was in Arabic. And now, in collaboration with his center, Rakhawi Center, now there is a committee to translate all his works, which we mentioned that, to the world. And I will contribute to just write a book about his profile and his production regarding this Dr. Yahya. Thank you.
Any further questions? Please go ahead.
I have a question to my mentor, Prof. Talat. If someone recognizes their own level of mental health, so if you recognize you mentioned 3, if someone recognizes their level of mental health, how can they remain there, or how can they slow down the reciprocal state of being that you mentioned? How can you slow it down because it's in a constant state of flow?
Can you just repeat the question, please?
So, Prof. Talat, you mentioned that there is a reciprocal state of being, right? And it's always in a constant motion. How can you slow it down in order to remain in the level of mental health that you recognize that you have?
How can you slow down the
reciprocal state of being that he mentioned?
The easiest thing is to give antipsychotic medication. The easiest thing, and he believed that antipsychotic is not just nothing but to stabilize the patient in a certain stage, and you are preventing him, depriving him from jumping to the next stage of development. This is one. And through psychotherapy, especially cognitive behavior therapy, by the way, I translated a textbook of Joe Speck, Cognitive Behavior Therapy, the basic and beyond. And I told her personally that your way of treating people or your school is just stabilizing what is in stabilizing, not provocative, okay? Not motivated therapy. He, Dr. Yahya, he said that if the bus is not in the proper direction, we can either redirect through milieu therapy. By the way, they won the first prize in the world in the milieu therapy, اللي هو علاج الوسط. Okay? Either through work, through play, through sports, through whatever, okay, and through psychotherapy, either to help the patient to trespass the obstacles in his growth, or to delay the pulse. He called the pulse. To delay the pulse to other circumstances, to other time until it is suitable for him. Okay? Did I answer your question?
Yes, sir.
And this is through psychotherapy. And he was mainly focused on group psychotherapy. Group psychotherapy, not individual psychotherapy. And he is the founder of group psychotherapy in Egypt. Okay? And now there is the World Association of Group Psychotherapy, and his daughter, Dr. Mona Rakhawi, she is a professor of psychiatry in Qasr Al-Aini. She is the vice president of the Group Psychotherapy Association in the world.
Thanks, Dr. Talat. Any further questions? Okay, please go ahead.
Thank you for all our speakers. I think it's been an excellent session. My question is related to digital health adoption and acceptance among healthcare providers. And I think in our part of the world, we continue to see this as a challenge where we don't have a limitation in terms of the resources for digital health, even within psychiatry. But when it comes to acceptance within physicians and other healthcare providers, there seems to be a resistance that we face despite showing them different applications. So is there anything from your experience that can sort of help bridge this gap of acceptance?
Yeah, excellent question. Actually, what has been happening is that if you see during the pandemic, everything, all of us we had no other option but to switch on to telepsychiatry. So in that way, I have been doing telepsychiatry for last almost 20 years. So it was very easy for me. But what I found was that people coming from far away in India, they were still saying, sir, we would like to come and visit you physically. So the mindset has to change. And what I found was that typically the people in the elderly age group, they were reluctant. So what I started doing was that during the pandemic, I would say, okay, you come on Skype and please bring your granddaughter or grandson. He will fix up for you, and that became a solution. So my staff would tell them, who is the youngest person? Just tell them, one. Second, the basic barrier is with us physicians also, the clinicians also. We are not very comfortable. So it's a process in which gradually things will change, and any change is not accepted immediately. And people who are actually very much interested in tech-based solutions, especially the younger generation. So I expect the budding psychiatrists, the younger psychiatrists to pick up these digital mental health solutions much faster than people who have been practicing. I will tell you another very important feedback which I got. As the chairperson of Digital Mental Health Indian Psychiatric Society, in 2022, I had the opportunity to get, when our president, Dr. Gautam Saab was there, we started a free helpline, and Apollo Telemedicine Network was with us, and we developed a special solution in which everything was paid by Apollo. And we started the helpline, and then I started getting the feedback that our psychiatrists are not very comfortable. So I asked the digital team to sit with me, and you'll be surprised that almost 80% said they are not comfortable with this process. So we had to have a training session in which we would, first the training was done by my team, then by the special IT team, then by coordinators. So it's a process, it will take time. But the most important thing for us to understand is that this is the time when now ChatGPT has come. ChatGPT means it is very next to impossible for you to guess who is writing what. If ChatGPT has come, so it's high time we start, making ourselves understand that digital services are here to stay, and we must acclimatize ourselves. It's a process, it will take time, but we have to somehow get used to it. There is no other option.
Any further questions to our speakers? I have a question. Yeah.
My dear friend Sandeep has beautifully put it. The question will come, especially the ethics behind it, the ethicality, ethics, and also the confidentiality part of it. So you have to take care, and also they might say that I didn't give you consent. So you have to really take this thing in the future. Yes. Okay.
Yes, it's a most important point he said about the security and data privacy. So we take an informed consent, and ours is an encrypted data. Everything is encrypted and it is HIPAA compliant. So these are basic what we said. Medical legally is very important. So you just should not say yes to any software person who comes and says we'll give it free. No. And especially our branch, we have to be very sure it's a very personal sensitive data. So that is something very, very important what Sir said.
I just have a question for Dr. Talat. You talked about what is happening now in Egypt in terms of trying to translate all the work done by Dr. Rakhawi, because obviously he's done a lot of work, but it's not internationally recognized. You talked about milieu therapy, and I remember a similar kind of therapy, but was popularized on a bigger scale, which is nidotherapy. I'm not sure how much you heard about it, but I think it may be the same as therapy, which is working on the environment, adjusting the environment, making a change in the environment in order to help the person sort of move forward. And one of them is recognized as a form of therapy, as a name, nidotherapy, whereas this therapy, because it was written in a local Arabic language, is not well known. So that probably comes to this idea.
Not exactly translate techniques, but the idea about the techniques, like we are translating from them to us, and we are inculturating what we translate. Also, we need to translate to the other language. They may take it or may not take, and they may take to modelize it to their culture. But he was always emphasis on the culture. The culture. You cannot treat the patient without his own culture and his own environment. And that's why an Egyptian way of psychotherapy, Egyptian school of group psychotherapy. Because unless you know the origin of the culture of this people, you will not.
Thank you very much, Dr. Talat. Any further questions before we bring it to an end? No? Thank you so much, Dr. Talat. Thank you, Dr. Bohra. Thank you, Dr. Mohandes.
Thank you so much to Dr. Hussein for chairing the session, our esteemed professors for their very insightful and stimulating presentations. Thank you for staying with us until this time. Thank you for the whole yesterday. Thank you for today. And by now we are coming to the end of the activities today. There was supposed to be a session which will be rescheduled for tomorrow. So this is the end of today. We hope to meet you all tomorrow morning. And I'll miss you all because I will not be available. I have a clinic tomorrow. So thank you. Thank you, Dr. Midhat, for giving me this opportunity to be part of this tremendous and amazing activity. Thank you so much. Thank you.